So let me introduce our next speaker. So I'd like to invite up Professor David Wood. He is a member of the Global Heart Hub Clinical and Specialist Advisory Panel. He's the Emeritus Professor of Cardiology at both Imperial College London and University of Galway, and of course to the NIPC Ireland, and a former past president of the World Heart Federation. So thank you very much for joining us. The floor is yours.
Thank you very much, and it is a great personal pleasure for me to be here and to support Neil Johnson and the whole team in bringing the patient voice to all of our work. And I'm going to try and set the scene for early detection and diagnosis of cardiovascular disease from a clinical standpoint. And first of all, to be clear about terminology, cardiovascular disease is an all-embracing term. It includes congenital heart disease, arrhythmias, heart failure, and so on. But in relation to patients presenting with a heart attack or a stroke or peripheral arterial disease, we are talking about atherosclerotic cardiovascular disease as the underlying pathology. And here is a picture on your left of an arterial wall pockmarked with yellow fatty deposits, and when one of these splits and releases its fatty content into the bloodstream, it causes instantaneous thrombosis, a clot, and that blocks the artery, and the muscle beyond that blockage is deprived of oxygen, and that produces the classical crushing retrosternal chest pain characteristic of a heart attack. And if you are fortunate to survive that acute insult to your heart and reach the hands of our interventional cardiology colleagues, they're able to open the artery and implant a small scaffold, a stent, to keep the artery open. The picture on your left shows the right coronary artery with a blockage halfway down, and then the blood flow restored with angioplasty and stenting. And this is truly life-saving, but actually it doesn't address the underlying pathology of atherosclerosis. And most importantly, about half of all patients presenting with a heart attack die within the first 28 days. That figure varies from one country to another, but the case fatality is about 1 in 2. And that is the main reason why we should be going into the population to screen for cardiovascular risk. To identify people early who are at high risk of developing cardiovascular disease, and to intervene appropriately with evidence-based treatments. Now, there are two very important principles in relation to introducing a screening program. Firstly, you need a validated and reproducible test. And secondly, you need an intervention which will favorably modify the course of the disease or reduce the risk of developing the disease. And we're talking here about either detecting asymptomatic disease or detecting risk of developing the disease, and there is a difference between the two. You see on the left here an example of imaging to detect coronary artery calcium, and on the right a blood pressure measurement. Now, screening for coronary artery calcium, normal on the left, and you can see the white calcific deposits in the left coronary artery on the right, and this indicates very advanced disease. Screening for asymptomatic disease has to be followed by a treatment. And screening for cardiovascular risk, and in Europe, we use the SCORE2 risk chart to detect high-risk individuals, and you can set the threshold here at any level you want, but the higher the absolute risk of developing cardiovascular disease, the lower the threshold should be to offer an intervention to reduce that risk. So we can screen for disease, we can detect coronary artery calcium in asymptomatic individuals, and we can measure risk factors and calculate their total risk of developing cardiovascular disease over a defined period of time, 10 years. What about intervention? What should follow that screening process? What is the evidence that if you detect asymptomatic disease with coronary artery calcium screening, for example, and intervene, offer coronary artery surgery, will it make any difference to the clinical course of the disease? And if you screen for risk of developing disease and intervene, will it make any difference to the clinical course of the disease? And the answer is that screening for asymptomatic disease, screening the carotid arteries, screening for coronary artery disease, screening for asymptomatic peripheral arterial disease, and there are some exceptions here, the evidence that intervening for asymptomatic disease will alter the clinical course is very poor indeed. Whereas screening the population for risk of developing the disease and intervening in those at high cardiovascular risk is supported by a wealth of scientific evidence. And therefore, national screening programs to detect individuals at high cardiovascular risk is strongly evidence-based, and we have a multiplicity of interventions in relation to lifestyle and control of risk factors such as blood pressure and lipids and glucose, and prescribing evidence-based cardioprotective medications which will reduce total cardiovascular risk, which will reduce the risk of developing atherosclerotic cardiovascular disease, which will improve the chances of survival. And we are now able to deliver such a high-risk strategy for our populations through interdisciplinary teams, working with nurses, with dietitians, with physiotherapists, with pharmacists, with psychologists, teams of people working together to help patients and their families to reduce their cardiovascular risk. And that care is now often provided in community rather than hospital settings. And with the advent of the COVID-19 pandemic and all of the consequences that we saw from that virus, much of the care that we now offer is coming in a digital form. So for patients who have survived that initial ischemic insult to the heart or to the brain or to the peripheral arteries, and for people who are found to be at high risk of developing cardiovascular disease, we have very, very good evidence that we can reduce overall cardiovascular risk, improve life expectancy and the quality of life for people. I was challenged once to define prevention, and I turned to my mentor, Geoffrey Rose, and he wrote in his short text, being healthy is better than being sick or dead. It is the sole argument for prevention. It is sufficient. Thank you very much.